Hello and welcome. In this video, we will discuss other portions of the audiogram test, including tympanometry and acoustic reflexes, which are both measures of impedance. Let's begin with tympanometry. These figures are tympanogram templates. Tympanometry measures the compliance or stiffness of the tympanic membrane. This is done by putting a probe in the ear, which contains a tiny speaker, microphone, and an air pressure changer. The probe emits a tone at 70 decibels and then blows a puff of air into the ear. The probe measures how much sound is reflected back by the eardrum during the different air pressures. This is plotted by measuring the pressure versus the amount of volume in the canal at the time. This changes based on how retracted or lateralized the tympanic membrane is. When you have a normal tympanic membrane, we expect the least amount of sound to bounce back to the probe at room air pressure, or at 0. This tells us that the pressure on each side of the tympanic membrane is the same, and it's called a type A tympanogram, and it looks something like this. If sound is reflected back to the probe the same at all pressures, the tympanogram will look flat, like this. This is called a type B tympanogram. This means that there is either a hole in the tympanic membrane or fluid behind it. We can tell which of these situations is present by looking at the canal volume measurement which accompanies the tympanogram. The normal volume in an adult ear lateral to the tympanic membrane is about 1 cubic centimeter. If the canal volume measurement is 2 cubic centimeters or more, this suggests that there is a perforation, and the measurement includes both the middle ear space and ear canal volumes. If the measurement is close to 1, this suggests an intact drum with fluid in the middle ear space. A type C tympanogram looks like this. This suggests that there is negative pressure behind the drum in the middle ear space. This usually means the patient has some eustachian tube dysfunction, in which the ears cannot equalize pressure correctly. At rest, the eardrum is retracted into the middle ear space. The last two types of tympanograms are AS and AD. These are more rare, but still important. They are both variations of a normal type A tympanogram. AS looks like this. You can remember this by thinking of the S as shallow. The eardrum moves, but not as much as it should, which suggests fixation of the ossicular chain or otosclerosis. AD, on the other hand, looks like this. And in this case, the D can be thought of as deep. The eardrum moves more than it should, sometimes even with the peak off the top of the page. This usually indicates ossicular chain discontinuity, which makes the eardrum floppy. The other type of impedance is acoustic reflexes. An acoustic reflex occurs when you send a signal through the afferent pathway of the 8th cranial nerve, and it sends a signal back through the efferent pathway of the 7th cranial nerve. This is done by putting a sound in the ear canal, which is transmitted through the cochlea to the auditory nerve. The pathway then travels through the efferent 7th nerve pathway, causing the stapedius muscle to contract. This, by the way, is the smallest muscle in the body. Specifically, an 80 decibel tone is transmitted at 500, 1000, and 2000 hertz. A response is not expected if you've got a conductive hearing loss greater than 40 decibels or a sensory neural hearing loss greater than 60 decibels. Let's trace out the entire pathway. Sound is transmitted to the auditory nerve, which then travels to the ipsilateral cochlear nerve, then to the trapezoid body. At this point, the signal travels to both sides, bilateral superior olives. This is important because a signal in one ear will actually make both stapedial muscles contract. From the superior olive, the signal travels to the facial nucleus, then out to the facial nerve, and finally out the stapedius, again on each side. A missing acoustic reflex may indicate a tumor or lesion along this pathway. Another test that is performed is the acoustic reflex decay, in which a sound is played into the ear at 10 decibels for 10 seconds. The stapedial muscle contraction is monitored. A loss of contraction prior to 10 seconds suggests a retrocochlear lesion. Let's do a few examples. Here's a person represented by a head. Here's the right side of the head, left side of the head. We're going to look at ipsilateral contractions and contralateral contractions. In a person with normal hearing, when you play the tone in the right ear, you'll get an ipsilateral and contralateral stapedial response. Same is true when you play a tone in the left ear. Here are the templates for our other examples. Let's discuss a person with a 70 decibel right-sided sensorineural hearing loss, remembering that greater than 60 decibels of sensorineural hearing loss will lead to an absent response. When we play a tone in the right ear, we don't expect a response either in that side or the contralateral left side. However, when we play a tone in the left ear, since that ear is normal, we expect normal responses. It should be noted that we expect the exact same findings when we have an acoustic neuroma in the right ear or another retrocochlear lesion. What happens if we have a brainstem lesion? In that case, when we present the tone into the right ear, we do expect an ipsilateral response, but it will not cross over to the other side, so we will not see a contralateral response. The same is true when we present the tone into the left ear. There is no crossover, so we don't expect a contralateral response. Finally, let's discuss a patient who has a 60 decibel right-sided conductive hearing loss. When we put the tone in the right ear, we get no response either in the right ipsilateral or left contralateral, as expected. But now it gets interesting. When you test the response on the left, you do get a ipsilateral left-sided response, but you don't get a right-sided contralateral response. This is because the same problem causing the conductive hearing loss, usually a middle ear problem, blocks the crossover response. This concludes our discussion about audiogram impedance testing. Thanks for watching.